Hello, everyone. Thank you all so much for joining me today. Today, we're going to talk about the Aminoglycoside Monitoring Program here at MGH. My name is Megan Adamsick, and I'm serving as a representative of the entire ID Pharmacy team who works to get this protocol and guideline approved and live here in practice at MGH. By the end of today's presentation, we'll have covered the Aminoglycoside Monitoring Program procedure, the pharmacist workflow and expectations. We're also going to discuss some clinical pearls and dosing schemes for aminoglycosides, given they're not as common in clinical practice as other antibiotics. But we'll first start with those workflow pieces and some of the expectations of the program of the pharmacist monitoring these drugs. If you're ever looking for the aminoglycoside guideline, you can find it in a variety of places, but all comes right back to Elucid. So the link here will take you right to the guideline in Elucid. If you're ever just on Elucid, you can always just search aminoglycoside and it should take you right there. It's usually the one that pops up right at the top of the list. If you use the partner's handbook in your practice on the clinical topics section under infectious diseases, you should also be able to find the aminoglycoside guideline there. And then if you're in the process of writing a note for a patient and using the aminoglycoside dot phrase for the note template, at the bottom under the signature, there should be a link that will take you right to Elucid as well. This guideline is very comprehensive and it includes treatment and dosing strategies for a variety of indications, including cystic fibrosis patients, both adult and pediatric, gram-negative infections for both adult and pediatric, adult non-tuberculosis mycobacterium treatment, non-extended interval treatment, neonatal extended interval regimens, gram-positive synergy, which is common in endocarditis, traditional dosing for both adults and pediatrics. We have a dosing recommendation section for obstetric infections. There's also recommendations for renal replacement therapy modalities when using aminoglycosides. And then there's also a section on aerosolized or inhaled tobramycin as well. At the bottom of the guideline, at the very end, there's an appendix for pharmacist expectations, and there's a tip sheet that includes a variety of helpful things that I would definitely recommend you to look at. So just a brief overview of kind of the flow from when the order gets placed and what are the expectations of a pharmacist monitoring aminoglycosides here at MGH. As with any order that comes to the queue, we ask that the pharmacist is going to consider which agent's being used for which pathogen, as that can change, the dose, the frequency, kind of the indication, or what dosing strategy we're using, what the therapeutic goals are, both peak and trough, for that indication, the patient's weight and renal function and clinical status should all be considered when we are assessing that initial aminoglycoside order. For intravenous aminoglycosides, all of them, regardless of the type or dosing modality, we do have a couple of requests and requirements for the documentation of those. So first off, we do ask that you open an IVEN, leave it open and review it daily. If it's easiest to put the entire dot phrase in the note, that's absolutely reasonable, although an abbreviated version is also allowed. As for other drugs that require levels and monitoring of close labs like serum creatinine, it's always a good idea and required for this program to put those items into the handoff action plan to do section, whether it's for serum creatinine or just to monitor the levels. And then if there are levels or an aminoglycoside is being started, a progress note in the patient's chart is required. So basically, if an aminoglycoside is being started, if we're changing the dose or changing the frequency, if a level results, or if a change in the patient's clinical status prompts a change in therapy, a progress note is required for each one of those phases of care. Now, a quick note on inhaled aminoglycosides. This is a really niche population that's going to tend to be receiving these, usually the lung transplant population and occasionally the cystic fibrosis population. So there are specific details in the guideline on what to do, when to write notes, and when to monitor. And usually that involves discussing with the lung transplant pharmacist. But there are more details in the guidelines on Elucid. So progress notes, as I mentioned, are recommended through a variety of different phases of an aminoglycoside treatment course. We do ask that an initial progress note is written when the initial order is placed. There are lots of clinical scenarios where an aminoglycoside is ordered but is not likely to be continued. For example, in septic shock, when the patient's very sick and you're not sure if the patient's going to receive it long term. So the rule of thumb is if the aminoglycoside is being started and will be continued for more than 48 hours, we ask that a note be written initially, or if levels are being obtained for that dose. So if you're going to give a one-time dose of tobramycin, but you are going to obtain levels, we do ask that the note is written. And the purpose of this initial note is really to convey to the entire healthcare team when the levels should be drawn and any appropriate monitoring and dosing regimen for this aminoglycoside. Now, subsequent progress notes are to be written when levels come back or there's changes in therapy. So if we're doing extended interval dosing and you're getting, a 2-hour and a 10-hour level, or in synergy dosing when the recommendation is for peaks and troughs, if you have 2 levels coming back, we should do the kinetics on them and write a formal progress note. If a single level is coming, meaning you're just kind of doing surveillance troughs to make sure that the patient isn't accumulating their aminoglycoside, it is asked that a progress note is written to document that level. And then, as I mentioned previously, if the patient's clinical status changes in such a way, whether their renal function decreases or changes in any way where you're going to change the aminoglycoside order, it's recommended that that is made clear in a progress note to the entire healthcare team. Now, sign-off notes were part of the previous aminoglycoside program, just specifically for cystic fibrosis patients, but given that these are going to be used more often because we've broadened the number of indications that are involved in this guideline, sign-off notes are no longer required. There's also some questions before I move on away from progress notes about when the order is started in the emergency room. So when aminoglycosides are started in the emergency room, it's usually very unclear the duration of that. And so the request has been made that if it's started in the emergency room, the admitting primary team pharmacist, once the patient is admitted, writes that initial note. But if the patient's levels have already returned, because the patient was in the emergency room for quite some time, it is not expected to write more than 1 note in 1 day. So no reason to write an initial progress note and a note discussing the levels on the same day. If we've kind of missed that window for the initial progress note, it's fine to skip it and just write those subsequent progress notes addressing the levels that have returned. So when those levels return, an appropriate level assessment is asked of the pharmacist, similar to any other drug that gets levels in our practice. There are 2 different aminoglycoside calculators on SharePoint, one specifically for cystic fibrosis patients and one for non-cystic fibrosis patients. And there are some directions here on how to navigate to find those calculators. SharePoint has been updated since the previous version, so some details here on how to find it. Basically, if you get to your Outlook Web Express, you can get to from either the P in the bottom left-hand corner of your computer or that menu button. And then in the small box in the upper left-hand corner, it looks like kind of 9 smaller boxes. You can click on that and navigate to SharePoint. If you have not used SharePoint before, you may have to search for MGH Pharmacy Decentral Clinical Services, and that should pop up right away when you search it. The calculators are stored in the shared documents section, and then you'll just progress through a series of folders to find the appropriate calculator for your patient. So writing a note, whether it's an initial progress note, a subsequent note for 1 level or 2 levels, or just a change in the clinical status, there is only one dot phrase to remember, and that is .agrx monitoring. And if you have questions on how to access this dot phrase, if it hasn't been shared with you, you can always reach out to another pharmacist or a member of the ID pharmacy team, and we can help you take that or add yourself to that dot phrase. But basically, the process is fairly simple. You'll click on the notes section in Epic, click New Notes. We do ask that these notes are written under the progress note subtype. The dot phrase can be typed in, and then you'll see a large template appear for you. And you can navigate through that template to different sections that require your responses, whether it's a drop-down menu or the 3 stars with either the F2 button or the yellow arrows at the top of the note writing section, and that will help you find all the pieces that you have to fill in. And there is example notes for initial notes, 2-level kinetics, single-level kinetics, or changes in their clinical status. There are examples of all of those note types in the appendix of the Aminoglycoside Monitoring Program guideline on ELUCID that have been shared. So feel free to look at those if you're wondering what your note is supposed to look like. But a rule of thumb, if you aren't going to use that section, it can be deleted. So for example, in an initial progress note, you're not going to have kinetics run because you haven't gotten any levels yet. So the kinetics section addressing all the different levels and then the pharmacokinetic calculations, that section can be deleted for that initial progress note. Another piece on writing a note is that if a note has previously been written, you are welcome to click the copy button at the top of that note, and it will copy everything that's in that note to a new one and then update it to fit your current status and your current situation. So for example, if a patient's having surveillance troughs monitored every 3 to 5 days, and you can copy the one from 3 days ago forward, update it with the new level and any other clinical monitoring and when the next level should be written, and go ahead and sign it. So it can be a little bit of a time saver to copy forward the note from previous, as long as it's appropriately updated. Once the note is done, we ask that you don't forget to update the action plan to do section of the handoff with any daily serum creatinine monitoring and timing of any other levels that are going to be drawn. And don't forget to open and keep open that iVent for ongoing monitoring and documentation. And that iVent really helps us look back at previous admissions and see what they've tolerated in the past. A quick note on consult teams. So there are a couple specific consult teams that are often going to be recommending aminoglycosides. If the patient has an active ID consult, feel free to call or page one of the members of the ID pharmacy team, as one of us is likely following that patient, and we can discuss any dose changes or recommendations in a more interdisciplinary way between pharmacy, us, and the infectious disease team. For cystic fibrosis patients, this protocol and process has not changed since the initial protocol in the years previously. And so it's recommended to page the pulmonology or cystic fibrosis fellow that's monitoring the patient, which you can usually find by looking at the notes section or looking at the on-call section of the paging directory, and to discuss any dose changes or recommendations. And then if they're in agreement, you can page the primary team to make dosing changes or recommendations in the chart. For all other patients, the primary team is going to be running the shift, and so you can page or discuss with them in person any changes or dose recommendations. This protocol and program is not, quote, pharmacy to dose. So all orders, whether it's levels or drugs, require a cosign, or the order mode should be applicable whether it's a verbal order or a telephone order with readback. Nothing should be signed as per protocol, no cosign required, because we do not have a per pharmacy protocol for this program. All right, so we've kind of covered the workflow and the expectations of a pharmacist within this program, but I will say that all of these are very detailed, all of these have very detailed explanations within the appendix of the Aminoglycoside Monitoring Program guideline. So if you have any questions or want further clarification, I would definitely recommend reading that section because it's very detailed and has a lot of specifics on notes and levels and things like that. But now we'll talk a little bit about clinical pearls. It's probably been a long time since most pharmacists use these, as they're not as common as some other antibiotics. So we definitely wanted to cover some kind of quick pearls that we use in our practice that may be helpful for all of you. So aminoglycosides are great drugs. They cover primarily gram-negative pathogens, but we do use them in gram-positive situations for synergy. And gentamicin is the only agent at MGH formulary that can be used for synergy, because the others are inactivated by the gram-positive organisms. Streptomycin can also be used, but it's not one that we routinely use here at MGH. And then gentamicin, tobramycin, and amikacin are all recommended for gram-negative infections, but their coverage can differ slightly. Gentamicin tends to cover those enteric pathogens, the ones that grow in your gut, whereas tobramycin tends to cover those non-enterics, more like Pseudomonas and things like that that may grow more often in lungs. And then amikacin is usually reserved for last line. It tends to hold on to susceptibility a little bit longer than gentamicin and tobramycin, so we usually tend to reserve it for multi-drug resistant, either enterics or non-enterics. Non-tuberculosis mycobacterium infections are increasing in prevalence. You may start to see this a little bit more in your practice. And it tends to be that amikacin is the preferred aminoglycoside in those situations, although there are some infections where tobramycin may be recommended, which is why there's that little mini check mark in that column. And really a key piece of information to remember is that the role for aminoglycosides changes depending on what type of infection we're treating. So in gram-positive infections, we're really just trying to improve that microbiologic clearance, but it's not our primary drug. It's synergy. It's just a bonus or a cherry on top to our primary agent, which is different than gram-negative infections, which is usually when we extend our coverage from our backbone or a beta-lactam. So if we're worried about Pseudomonas being resistant to cefepime or meropenem, which is what our primary agent is, perhaps we might add tobramycin to kind of expand that coverage from our backbone, which we use routinely. Aminoglycosides are 100% renally eliminated, and so monitoring renal function is crucial. So we'll start first with extended interval dosing, and this applies to several different indications within this guideline, from cystic fibrosis to gram-negative infections, and also non-tuberculosis mycobacterial infections. And this just means that we're giving higher doses less often when we compare that to traditional dosing, which is usually on a Q8 or Q12-hour regimen. And this is because we have learned over the years that aminoglycosides are concentration dependent, meaning that the higher the peak, the more kill of the bacteria that we are able to achieve. So as an example, in Pseudomonas, research has shown that a peak ratio to the MIC of 8 to 10 is more efficacious and shows more bacterial killing than lower peaks. So because of this, it's recommended to maximize that peak and allow the patient to clear the drug to undetectable or very low levels. But we want to maximize that peak, but also keep it safe. So there are upper end goals for the peak as well. It's not just above 16, for example. We definitely want to keep it safe, but maximize that because that is what's going to be treating our infection in extended interval dosing. So a question that we get often is why are we getting 2 and 10-hour levels? So you can see here on this graph, time on the bottom and the concentration on the y-axis, and then you can see that the infusion is given. There's a slight distribution phase, and then we continue through the rest of the clearance curve. And we get a 2-hour level so that it's after the distribution phase once the infusion ends. And then we get a 10-hour level because it's about 1 to 3 half-lives apart from that first level. So you can imagine if you got 2 levels really close together, perhaps your clearance might not be as accurate. You could have falsely steeper slopes or clearances or more shallow slopes or clearances, and it could give you false numbers in your KE, which is going to help you calculate your Cmax and your Cmin. So a 2 and 10-hour level is not a peak and a trough, and that's where we use pharmacokinetic calculations to kind of back calculate what that Cmax is and what that true Cmin is. So as I mentioned, peak or Cmax is our marker for efficacy. So we definitely pay close attention to reaching the value of our peak within our predetermined goal without being super therapeutic. The trough, or the Cmin, is our marker for safety. So we monitor this in order to decrease the risk of AKI and ototoxicity. And once the peak and trough are in goal, it's really only necessary to continue monitoring trough because we know that this dose is likely going to reach that peak, but we want to make sure that the patient doesn't slowly start to accumulate the drug, meaning that their trough starts to rise. And so once that peak is in goal, the trough looks good, it's usually recommended to get a trough every couple of days, anywhere from 2 to 5 days, depending on the patient, unless a dose change is made, which is then when we would recommend another peak and trough. So these are just some really helpful pearls to review when you're making recommendations. So we'll just discuss them quickly. So if your peak and trough are both at goal, you've done it, and you can continue your current dosing strategy, and we can move, like I mentioned previously, to surveillance trough monitoring only on some regimen, some interval that makes sense for that patient, usually somewhere between every 2 to 5 days. If your peak is at goal, but your trough is high, that suggests that you have given enough drug to reach your peak, which is our goal, but your patient's just not clearing the drug fast enough, and so it's recommended to extend that interval from, say, Q24 to Q36. And because you already know that your peak has reached its goal, you can consider just surveillance trough monitoring at that point, rather than continuing to get 2 levels with each set of monitoring. In the next scenario, where you have both your peak is above goal, or excuse me, your peak is above or below goal, really, but your volume status is normal and your trough remains fine, we usually recommend to change the milligram of the dose, but keep that interval, because if your trough is at goal, you're usually able to say that your patient clears the drug fast enough to keep at that interval. But like I mentioned before, we really want our peak to be in that range. And so whether it needs to be increased or decreased, that it depends on if the peak is high or low, but you can keep the interval the same. And then because we changed the milligram dose, we want to repeat a peak and a trough monitoring. If your peak and trough are both out of range, it definitely depends on the clinical scenario and clinical judgment to assess the situation and are the peak and trough high or the peak and trough low. But basically, you want to use your clinical judgment on whether or not you should change the dose. But either way, you should probably consider repeating those levels. And again, the ID pharmacy team is here to help. We understand that these are less commonly used drugs, and so we're more than happy to help assist in those trickier situations. One of the questions that I get a lot is, well, when do I know to hold the dose? So the risk of toxicities associated with aminoglycosides are really that renal toxicity and that ototoxicity, and those risks are higher when we have prolonged elevated troughs. So like I mentioned before, our trough is our safety endpoint. It's what we're looking at to make sure the drug is still being used safely and not going to cause harm. So here are some scenarios to consider when you are using these in practice. If the trough is mildly elevated, but the serum creatinine is stable, then it's reasonable to just prolong that interval out 1 step without holding a dose, because it's only mildly elevated and your patient's renal function remains stable. So for example, if you're at Q12 dosing, you can move to Q24 dosing. If the trough is significantly elevated and the serum creatinine is stable, you could consider prolonging the interval and holding a dose, probably prolonging the interval either way, and then depending on the degree of elevation of that trough, you can decide if holding a dose and rechecking a level is required. But because it's significantly elevated, it's usually recommended to recheck that level before we restart, just to make sure that the patient has cleared the drug appropriately. And then lastly, if the trough is elevated and the serum creatinine is elevated, this suggests that you have gotten to that point where your patient is having some toxicity, likely from your aminoglycoside, and we recommend holding further dosing and rechecking a level before restarting any aminoglycoside dosing. So volume of distribution is actually super important in aminoglycosides, because they have such a small volume of distribution, usually somewhere in the 0.2 to 0.4 liters per kilogram. And this is why we use ideal body weight, adjusted body weight, or even, total body weight in patients who are of normal weight. And that's why it's recommended, because it's not going to distribute to your tissues. And so if you have a patient who's morbidly obese, even if they're 200 kilos, their aminoglycoside is really going to stay within their vasculature and not distribute much out to their tissues. And because the volume of distribution is so small, very small changes in the patient's volume status can drastically skew our levels. Because if you have a patient who's usually very small and petite, and or even cachectic, but you volume resuscitated them with 3 or 4 liters, then their very small volume is now increased by 3 or 4 liters, and that can drastically change our Cmax and Cmin levels. So it's always a good idea to address the volume of distribution, which is why it's in our recommended calculations if you're doing it by hand, and it's also going to automatically calculate in our calculators that you may use in your practice. So first things here, if your volume of distribution from your pharmacokinetic assessment appears high, suggesting that it's more than 0.4 liters per kilo, it may be something to consider of rechecking those levels when the patient is more euvolemic, because those levels might be falsely low or really diluted out because there's more volume on board. In contrast to that, if your volume of distribution appears high, excuse me, there's a typo there. If your volume of distribution appears low or less than 0.2 kilograms, consider rechecking those levels when the patient is more euvolemic, because that might be falsely high, because you have less volume for that drug to dilute out into, and so it may appear higher than you expected. I apologize about the typo. That last line should say low rather than high. All right. So some gram-positive synergy pearls. So previously we talked about extended interval dosing. Now we'll move more to that synergy, which is the other common reason why we would be using aminoglycosides in practice. So as I previously mentioned, gentamicin or sometimes streptomycin are the only agents used for gram-positive synergy. And in synergy, those really high peaks are no longer necessary because we don't have targets like what I mentioned previously of Pseudomonas, 8 to 10 times the MIC. We're really just here to enhance the bacterial kill. And so we don't necessarily want to get those peaks that high because we don't need them. So the rule of thumb for gram-positive synergy is typically somewhere around the 1 mg per kg dosing, and then the frequency is dependent on age and renal function. So this is a screenshot here at the bottom of the table within the aminoglycoside monitoring program guideline, and it's kind of pieced together from a bigger table. And you can see that the recommendation for adults and pediatrics is 3 milligrams per kilogram per day in 2 to 3 divided doses. And you can see there at the bottom, the interval depends on how the patient's renal function is doing. So if you have a patient with very normal renal function, they're a young patient, et cetera, Q8 is likely reasonable, and so 1 mg per kg Q8 dosed appropriately for their weight is recommended. Now, I will say that in patients who are elderly or on the older side that have apparently normal renal function, we may recommend to use caution in those patients. And even if they are, 75, for example, but have a creatinine clearance of 80, we may recommend just empirically starting a Q12-hour regimen because of their age, and that likely creates just a slower renal function, more of a false appearing creatinine clearance. Another note, you can see at the bottom that it says 3 mg per kg Q24 can be used in certain clinical scenarios, for example, streptococcal endocarditis. So the endocarditis guidelines do recommend 3 mg per kg Q24 in patients with normal renal function. So that is something that you may see in practice, and that comes directly from the guidelines. And another note here with synergy, the rule of thumb that we use in our practice is really to round down in most situations. This is really just an add-on drug. It's not our primary agent, and so we would hate to cause harm from a synergy agent. And so if there's an opportunity to round down a little bit, it's usually recommended because it's always easier to increase the dose than undo an AKI. And then in gram-positive synergy for how to monitor levels, peaks and troughs can be monitored initially, but similar to our extended interval dosing, once the peak is in goal, you can usually monitor troughs only, and this is just to monitor for safety to make sure that patient is not accumulating the drug and continues to clear appropriately. I will add that in some cases, infectious disease providers will recommend not monitoring peaks, and this is mostly because we don't have peak targets or peak to MIC targets, and so some providers are comfortable without monitoring that peak because our goal is not as concrete as in gram-negative infections. All right, so lastly, we'll just talk about a few calculation pearls. So if you're progressing through the variety of aminoglycoside competencies as part of your onboarding or credentialing process, we do ask that the kinetics are done by hand just to see your work and help kind of work through the process and see why each equation is important to be part of the process. And so here are some commonly asked questions about those calculations and some tips and tricks. So Within the aminoglycoside guideline, you can see that there's a whole list of helpful equations, and these are the ones that we recommend using, and these are also the equations that are embedded within the calculators on SharePoint. You can see that there's a legend on the right that will kind of take you through what each piece of the equation means, and that will be very helpful in doing the equations by hand. A very frequently asked question is, what is T1? And so this is part of the extrapolated peak equation. You can see that it's on the bottom half of that fraction, T1 minus T prime. And so T1 is the time when the first level is drawn. And so commonly, one of the challenging pieces about this is because we aren't as familiar with these drugs in our practice, just because they're less common, we forget a little bit about how what to put in for each integral and which variable in the equation. So T1, when you're putting these times into the equation, it's not necessarily the exact time. It's really the difference between times usually, or the number of hours between this and this. So this specific equation is asking for the number of hours between the end of the infusion and when the first level was drawn. So you can see here in this diagram on the bottom left, you see T prime, which is when the infusion starts, all the way through the end of the infusion. And then you see level 1, or C1, and that is the time that the infusion is, the first level is drawn from the start of the infusion. And so this piece of that equation, T1 minus T prime, is the time from the number of hours it took from the end of the infusion until when the first level was drawn. All right, everybody. So thank you all so much for listening. Hopefully this presentation was helpful for you as you progress through the aminoglycoside monitoring program credentialing process. Again, if you have any questions about this process, the ID Pharmacy team is an available resource. We're willing to help and available, so just definitely reach out to us, review these slides, review the guideline that's posted on Elucid. It'll have a lot of helpful tips and tricks as you go through this process. Thanks all for your attention and listening today.